We have the opportunity to hear from some of our colleagues who are involved in leading and managing bloodless medicine and surgery programs, as well as from some of our patients who had experiences and been through a lot, but are here to tell us the tale. We'll start with Rob, and I think most of these folks, again, have been in the field for a long time, but you can speak briefly about what you do.
21 years now. I did my clinical training at a level 2 trauma center that I worked for 15 years. And to be yanked out of that setting and environment into the bloodless world was just refreshing. Wonderful, wonderful to see how things could be done. So the transfusion-free, we know the nickname Bloodless Medicine and Surgery. We know that there is blood that will be shed in the OR, that happens, but transfusion-free is avoiding allogeneic blood. And autologous blood, not pre-donated, is something that can make a big difference, cell saver. We use that. So my role now at this new setting, new hospital, which is exciting, is almost 600 beds. It's the only burn unit in New Jersey. And so they can fly patients in as needed. They also do transplant surgery for kidneys and pancreas. So I'm a part of the Patient Blood Management and Bloodless Medicine and Surgery Program. I'm a part of the Anemia Clinic where we do IV infusions of iron, which has been wonderful, wonderful outcomes, avoiding blood transfusion becoming an issue. So I see that the planning, the implementing, and even evaluating afterwards to see what the outcome looked like. If there's a need to tweak anything, we do it to make any improvements. Our department, we have 2 directors, medical director and administrative director. We have 2 advanced practice nurses. We have a registered nurse that we work together in the anemia clinic. We have a coordinator for the office, and we just added on an ICU doctor who's really excited about embracing the program. And just one more thought that I found very exciting, and you probably already know that now they found a way to reimburse for what I do, which is patient education. When I first saw that, I saw the list when I was doing my chart review of all the patients, and I saw that Jehovah's Witness was under problem. So I ran to the director, Tanisha, a problem? We're a problem? She said, oh, don't get so excited. It's a good problem. It's a problem that can be addressed by your educating the patients so that our doctors can have the necessary tools in the OR. So now they finally found that it's worthy of reimbursement because it is a chunk of time, as Sherri knows. I've met even other nurses, fellow nurses, that didn't quite grasp all of the different options, the fractions, and so on and so forth. If you're not in this world, some of it seems foreign if you never had a real serious problem or a need for major surgery.
Thank you. And now we'll move on to another one of our colleagues from across the United States. On the other side, we have Joe Bishop with us from a program that's been around for many years and dear to my heart, but has changed names a few times, I think, as hospital systems have been absorbed and reabsorbed. But he's from the Virginia Mason Franciscan Health System, which is up in the Pacific Northwest of the United States, in the Tacoma, Washington, close to Seattle, which most people on the call have probably heard of. So Joe, would you make a couple comments about your bloodless medicine and surgery program and how that connects to improved clinical outcomes and why that is from your perspective?
Our program has been in existence, serving transfusion-free patients for more than 23 years. And it's evolved from basically a one-person operation to about seven staff plus volunteers that work with the program. We do see a lot of our patients directly still, a lot of bedside care and so forth. Regarding the question of improved outcomes, I'd like to say certainly other types of programs are also able to achieve improved outcomes. Other programs that reduce blood transfusions are able to achieve improved outcomes. But a bloodless medicine and surgery program has several distinct advantages. Number one, it's patient-centered, of course. Patients are requesting this rather than it being kind of a top-down decision. Patients are asking for bloodless medicine. So being patient-centered improves, of course, clinical outcomes. Likewise, another advantage is it sets the highest bar. These patients will not accept blood transfusions. That's the highest bar, and that really challenges clinicians to really implement cutting-edge technology and be on the top of their game, and that certainly improves clinical outcomes. And likewise, as Dr. Spies was mentioning earlier, it encourages interdisciplinary collaboration, and we know that that always tends toward improved outcomes. But I'd like to mention and focus on one more advantage of a bloodless medicine program, and that is that it is easily incorporated into the standard model for quality improvement. The structure of most bloodless programs inherently matches the design of the quality improvement model. And what does that look like? Well, an organization has an idea for improvement and a plan for change, first step. Second step, they test or pilot that change on a small scale. Third, they study the results and make any needed adjustments. And fourth, they implement the change in a wider and wider setting. So what does that model have to do with bloodless medicine and surgery programs? Well, imagine a healthcare system that wants to implement best practice by reducing blood transfusions across their entire organization. Who already has a plan for that? Who already is implementing it on a small scale? The bloodless medicine and surgery program. If an organization has a bloodless medicine and surgery program, those steps of planning and implementation are already in place. The bloodless program likely has decades of experience serving a small population, and it's already up to date on the latest evidence-based practices. So the template and the pilot program are already there. The interventions and protocols that are already resulting in better outcomes in the transfusion-free population can be progressively implemented in wider settings, bringing improved outcomes to more and more patients. And I'd like to say that that implementation in wider settings really becomes turbocharged when leadership, the C-suite, sees the value of reducing blood transfusions. And that's where the organization that I'm affiliated with is beginning to come on board. Our transfusion-free program serves 6 hospitals, but our parent organization is comprised of more than 140 hospitals, and they are now looking at implementing patient blood management across 140 hospitals, and they're looking at our transfusion-free program for policies, procedures, interventions that can be used not just on transfusion-free patients, but on all patients. So the benefits of bloodless medicine, the improved clinical outcomes is spreading to a larger population, and is taking place quite rapidly because now people at the top are seeing the value in it. So yes, I would say that a bloodless medicine and surgery program is the ideal setting to achieve improved clinical outcomes in bloodless care.
Joe, thank you so much. I mean, I really like the comments you made about fitting into the quality framework. I think that has been a little bit of a challenge, which I think we've adjusted to in the bloodless world over these years. This is, I think, 28 years for me in the space. And I think that when we first got started, we did speak a little bit of a different language. And I think that, you know, the bloodless programs for a long time were kind of off to the side in many hospitals, something that was really nice or respected, but didn't quite look or feel like, you know, the initiatives that hospitals were taking on. But I like your alignment with that to recognize quality processes, quality improvement processes. I'll make one other comment where I think that We now talk a lot about disparities, right? Both in medical and nursing education and in hospital settings. We talk a lot about population health. And really, to me, this bloodless medicine and surgery programs were the earliest model of addressing population health and disparities in a community and in a healthcare setting. So again, I think the more that we can speak the language of the institutions and the organizations with which we interact, the more and more recognize, I won't even say acceptable, recognize the importance of bloodless medicine and surgery will be to hospitals. But again, it's important again for us to, I think, understand where that fits so that our colleagues understand its value. So thank you for those excellent comments. You're a nurse administrator, my good friend and colleague on multiple projects now at the Patient Blood Management and Bloodless Care Program at ProMedica health system. That's in Toledo, Ohio, here in the United States as well. So if you could help us a little bit, comment on the pillars of bloodless medicine and surgery and some of the associated techniques, and a little bit about how your program works there. And I think you're a more recent entry into the field of bloodless than some of us ancient fossils on the call. So any of your insights too are appreciated.
So I entered the bloodless care realm in 2017. And at that time was charged to try to concentrate on expanding the program into patient blood management, which, to our team is very much the same practice, just expanding it to everyone and giving everyone that better standard of care. So we expanded our team from a size of 2 nurses to a size of now we have 6 RN nurses and 1 advanced practice nurse, medical director who also is a hematologist, and we have a patient care coordinator who kind of manages the office, and that's working out really well for us. So our team manages both an inpatient and outpatient realm. We round on patients and we monitor their daily treatment plans. We monitor the condition of their health, their blood health, and take quick intervention and interdisciplinary communication with the different multi-collaborative people that we need to collaborate with so that we ensure that we are practicing bloodless medicine. And then also we have our telehealth anemia clinic where we do a lot of pre-op anemia and a lot of OB population. And so in the OB world, that makes up about 36% of our consults. And so last year we served approximately 500 prenatal visits. And really the 3 pillars or standards of care, we start with the comprehensive anemia assessment, their blood health assessment. ProMedica practices doing a comprehensive blood panel workup at time of discovery that we have a pregnancy. So we do have early consults to our program. And we evaluate ferritin, current hemoglobin, CBC, iron, B12 folate. And this gives us the opportunity then to visit with the patient and really do a good historical assessment as well as current state assessment and explain to them the goal, where we want them to be at time of delivery. And it has enabled us to be able to catch, you don't want surprises at time of delivery. And so we have been able to identify blood disparities that we did not know going in. So it's really great to have that plan and follow that pregnancy all throughout delivery. And we know that 60% of women who experience postpartum hemorrhage had no risk factor. It continues to be a health emergency that really a lot of the people who experience it had no risk factor going in. And so to have a prepared plan in place, and to make sure that they go in with the best blood health possible is the number one thing that you can do. So the primary reason for anemia in pregnancy we know is iron deficiency, and that seems like an easy correct for us. We make sure that mom is taking oral iron in the first trimester, and by the time we get to the second trimester, if she's still struggling, we do move to intravenous iron, because we want best benefits for both mother and baby. And so then we move on to the second phase. When it gets close to delivery, we want the minimization of unnecessary blood loss. And so our team and the OB team, we've taken a lot of time to develop those relationships so that they know everything we discovered through our blood health assessment before delivery. And so they know then whether to plan for cell salvage or any other thing that might cause additional bleeding. Postpartum hemorrhage remains common in obstetrics. In 2015, globally, 275,000 mothers lost their lives, and so it's still very significant. So the minimization of unnecessary blood loss really falls into the hands of the clinical team that we collaborate with, but things that they are prepared for is rapid response to a hemorrhage. The balloon catheter, if there's placenta abnormalities that they know of, is something that they use. Other things can be compression sutures. They pay close attention to uterine atony, all those reasons for the post-operative hemorrhage. And just really understanding what normal blood loss is and being able to measure it correctly is very important to our medical team. And then if there's anemia post-delivery, our team is brought back in to do what we do best, which is to make sure that mom goes home with all the building blocks that she needs. So we play the role of pillar number 3, which is harnessing and optimizing the patient's blood back to normal if possible. So postpartum anemia, 24 hours after delivery, if it's under 10, we consider that postpartum anemia. We want to make sure that she has what she needs before she goes home. It can at times be more iron. And then hemoglobin at 1 week, if it's under 11, we consider that anemic if she's 1 week postpartum. And then 8 weeks after, she should be at a normal hemoglobin of above 12. And so we follow her until that 8-week checkup. We will run her lab scan and we can educate her about where she's at. So that's kind of our operation in a nutshell and as it relates to the OB sector.
Thank you so much. Excellent work.